Good morning. Probably a more didactic kind of presentation than I gave yesterday afternoon. But what we want to look at, and we've heard so much about evidence base, and really what I want to try and do is bring that home to you at whatever stage in your career you're at. Probably there are many definitions on evidence-based practice, and one of the most traditional is this one by Sackett, where it's the conscientious, explicit, and judicious use of the current best evidence in making decisions about the care of the individual. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external clinical evidence from systematic research. Now that sounds lots of big words, but really what we're trying to do is get together the actual knowledge and expertise of the individual and match that with the external evidence, what is out there. And that gets us back into lifelong learning, being able to prove that you're competent to do the job that you're doing and to promote the role of the profession that you represent. But this is very much, as a lot of our history and heritage comes from, is very much a medical model. And when you begin to look at being a dietitian and an allied health profession, we begin to think what potentially are the flaws or the problems with this definition. Really what we're looking for in dietetics, for example, as we've said, we don't maybe have the best quality research. It's not available yet. That's what we, me and you, have got to produce. There are so many dietetic areas that remain under-researched, and that can be a problem basically because food is part of every treatment, part of everything that we all need to survive. I think, again, it's very much looking at if you don't change your clinical practice, if you don't see what's good out there, your practice becomes ineffective and your patients don't get the treatment and the care they actually need. And as I said, that as well gets us on to our patients. Thinking about what we said yesterday, being able, through the work of a dietitian, to involve our patients, to understand them. We've got to understand them. We've got to understand their background, their circumstances, their family conditions, their family circumstances, because that is very much the... Oh. Should I grow? Thank you. That's very much part of how we actually find out about the food they eat, why they eat that food. So, how do we involve our patients more? Do we use focus groups where we actually bring our patients together to ask them what they want, what they actually feel they should be doing? Do we look further at how we motivate them? Are they ready to change? Are they ready to take on board what we need them to do? So again, the problems with the first definition, as we try to make it slightly more allied health, we come up potentially with another definition, and this is much more, again, moving to a nursing definition. And again, it's beginning to say we do need to have the patient there. We do need them to suit what's best. But we have our own definition now of evidence-based practice that came from the International Confederation of the Dietetic Associations in 2010. This sits very comfortably with me. It's about asking questions. It's about systematically finding what research is there and what's available. It's about assessing validity and application and the importance of any evidence. And then it's combining that with the dietitian's expertise, their judgment, and the client's or the community's unique values and circumstances to guide decision-making in dietetics. We've gone from a medical model to something that fits our practice. And I think that is one of the things that we've got to emulate as we go through. Because what we're doing with that definition is we're integrating a sound process, but we're looking at the unique skills of dietitians. Some of the ones that we were discussing yesterday. Some of the things like dietary assessment. Who else can do a proper dietary assessment? Who can work with our patients to devise a nutritional care plan which is going to best meet their needs and is going to optimise their nutritional intake? As we've said, the client's involvement crucial. And Ethan was saying earlier on about simulations and actually having the service user there as well in some of those simulations, or taking it that little bit further to integrate service users into the teaching and academic teaching, so that again students are beginning to know how to speak to patients, how to begin to actually have that integration into the world of work. So really what we're showing is that evidence-based practice sits very much at the middle of the client and how they are, at research, and at the expertise and experience of the dietitian. So what are the 5 stages of evidence-based practice? We've got the question. Really what we're doing is we're recognising that there's a need for new information, and we've got to convert that into an answerable question. The reason I put PICO, are people familiar with what PICO is? No? PICO, it's standing for P, for patient or problem. It's thinking about the patient, the problem. I is for the intervention. C is if there's a comparison. And O is for an outcome. So if I give that in a dietetic example, because that sounds, again, very scientific. If we had an older person who had a significant pressure ulcer, if we give them diet A, or if we give them diet B, which diet would actually heal that ulcer quicker? So you're looking, the question, the patient has the wound, has the ulcer. We're looking at, is it diet A, diet B? So we're comparing the two, and the outcome, which one actually heals that ulcer the best? Does that make sense? And I think if you get into that habit of actually looking at what you're doing, it's one of the things that you can begin to go through, because that's an example that you will see. It's an example that is real to you, and you can do that for every patient that you see. So you're thinking the whole time about what is the best practice I can give, what's the best evidence I can give to my patient. So finding, where do we go to even find the evidence? You do it all the time. You look at textbooks, you go on the web, you look at e-journals, you look at research papers or published papers. There's PubMed, there's Medline, there's Cochrane collaborations. There is a wealth of information out there where you can find the information. And I think, again, textbooks, just to be aware that I think as technology has improved and fastened so quickly, as Bert was saying earlier on, things are moving so quickly that some textbooks are almost out of date by the time you actually get them. So watch when things are actually said. You then want to look at that evidence and appraise it, and it's critical appraisal. It's determining, is it valid? Is it useful? It may be, it may not be. The kind of almost the gold standard would be something like looking at meta-analysis or looking at a systematic review, coming down to a randomized control trial or a cohort study or down to case studies. And I think for dietetics, it's the wealth and the breadth of that that is important. There's a lot of things that we don't have the meta-analysis for, but we do have case studies. We do have good practice across the world, and those can be the best evidence that you have. It can be quantitative, but equally the qualitative information is now being recognised more and more in well-standing research journals or research publications. Again, allowing us to publish the work that we do. There's acting on the evidence. You've then got to decide, is it okay? Or no, throw it out, not going to change my practice. And again, about evaluating and reflecting. The words always come up. You've got to think about what you do, evaluate that, and reflect. Did it go well? Would I do something different again? Reflection, very, very, very much part of the role of a dietitian. So really the reflection there is, well, did diet A work better than diet B? That's really where we're trying to get to. Oh, it hasn't come up. What that slide was just showing that as a nice little circle, that everything goes in a circle. Okay, you start, but when you evaluate and reflect, you then have got to ask that question again. So keeping the circle going. This is a busy slide. But hopefully, if we break it down, what you want to be as dietitians, you want to be clinically effective. You want to make sure that what you do is the best that you can. So if we start up here in research, research is something new, and we'll talk a little bit about the differences in some of these in a few slides' time. Something new, actually saying we're doing a new thing, a new hypothesis to test, something novel. That's where, if the research is there, systematic reviews can then happen. And then the clinical guidelines are produced. Clinical guidelines basically telling you what is the best way to practice. The word standards, we've heard an awful lot about the word standards. We've standards for this and standards for that. That's what we need. We need to know that that is the best practice at the time, and we then measure our practice against that. That process is called audit. What I'm trying to get through to you is that sometimes we hear research and we think that's somebody else's job. That's not us as dietitians. We're working with patients. What research is there to do? There's a role for all of us in lots of different ways in producing papers to produce the best evidence possible. So I said the audit is there. We adapt that to get our practice, provide effective care, and then we monitor. That might change the standards. That's fine. But again, everything we do, and that's why I keep thinking, everything runs almost in circles. And that's the way that we need to think about some of our practice. Again, research or audit, they're both rigorous processes. They both follow a methodology. There's a design, there's a procedure, you analyse it, you interpret it. But quite often, there's a blurring between the two topics. And some of the slides, if you go into any of the ethical approvals, you will very clearly see this is what audit is and this is what research is. We're looking at audit, which isn't about experiments, whereas you might find research is about experiments, more likely to involve experiments in human subjects. Audit, systematic approach, you're peer reviewing what already is there, looking for opportunities to make things better. Research, again, a systematic investigation to increase the amount of knowledge. Audit doesn't involve putting patients into different treatment groups, whereas research may do. Audit's not a completely new treatment, whereas research may be. Audit is about not disturbing patients. You're going to give them the clinical care that you do, whereas, as I said, for research, you may be putting them into different categories and asking them to do something more than what you normally would do in a treatment. But I think, to me, the key for a lot of it is that with audit, you're measuring a standard, whereas with research, you're going to test a hypothesis. The other area that comes in and fits very similarly along these guidelines is service evaluation. As a dietitian, are you doing what you need to do best for your patient? And so if a dietitian's working, we did a service evaluation on the school's dietitian. We went in to see, was what she was doing in the schools effective? Again, logical process, but following a very process-based approach. I know there are many different bodies throughout the world that actually produce these guidelines, do the research as such for us. In the UK, we have the National Institute for Health and Clinical Excellence, NICE. Again, NICE is an international body and is now being recognised much more for a lot of the work that it's doing in China, in Asia, looking at health problems. Because what it's there to do is to promote good health and prevent ill health. It's produced by people like ourselves, people who work with health and social care, who work with the public. It's looking at best evidence. Again, it's looking, is it good value for money? There may be a drug that is absolutely fantastic, but it costs too much money for the worth, for the amount of people that can get the benefit from that. So as I said, a lot of the bodies do this and they have the clinical guidelines, but I get frustrated because quite often it doesn't mention dietitians. We're getting better at getting into these bodies, but it's not saying that dietitians aren't important. We have, for example, some of the guidelines in nutrition support. We have guidelines on irritable bowel syndrome. We have guidelines on diabetes. The job of the dietitian, if you're not mentioned in there, is to actually produce your own evidence from case studies to actually say, do you know what? We do make a difference here, and that's your selling point. So getting back to relevance. Are we relevant? Is evidence-based relevant to dietitians? We've used the word so much. I personally think it is crucial. I think this is the pinnacle point that gives us and gives our profession total credibility. Evidence-based is used to make decisions in all areas of dietetic practice. The outcome and the reason why is we want to improve health outcomes in individual clients, in communities and populations. And also at the same time, we want to promote the role of the dietitian. Evidence-based practice clearly states the source of evidence which underpins anything we do. We must engage and integrate the knowledge of other disciplines because we don't work alone. We work as part of a team, and we've always got to remember that. And again, it must be informed by ethical principles and by codes of good practice. Again, things that are crucial, things that are already there. I think it's one step forward to making sure our clients do get the best service that's possible. But like Jessie said as well, students may keep you up to date. Evidence-based practice as well keeps you up to date, which keeps your students up to date. And I think I would actually question, I think it's unethical to use treatments that you know, or whether you mightn't know whether they work. You've got to know that that's the best for your patient. The associations that actually then can come on board, and we've heard a lot about what they can do. I think the first thing that I must say is, as dietitians, we must be able to think critically so that we can understand and we can apply any evidence-based practice that is relevant to us. The associations can point us in our right direction. They can produce the resources that we've talked about, the journals, the newsletters, the websites. They give us information sharing opportunities, either among ourselves or across the wider Europe or wider world. They can provide training. They can almost put in place communication networks. That networking that I go, networking and me, back to that again. There's the benchmark statements that we have from IFAD that again have allowed such a progression throughout Europe. We have online knowledge translation tools. Now what, for me, that is in my area of practice, my association is part of a global online knowledge translation tool which allows our members to access a breadth of available knowledge base that we can actually have succinct answers to thousands of practice questions. We can use it while we're in practice. It also gives us time to research outside that practice. And it's linking original research and guidelines to our clients, to our practitioners, and again allows us to have dietary resources that are there. So with ourselves, with our associations, what we can do is we can enable the dietitians, the members, to systematically evaluate the quality of practice, to revise practice on the basis of feedback, to improve our services and practice, and to maintain a continued competence to practice. Had to have a picture somewhere. Be it your fairy tale castle, be it your ivory towers, I don't care. Research, audit, evaluation is something that we all must do. It's not something you leave for somebody else. And I think if you really believe and strive to do the best for your patient and your clients, then that's evidence-based practice. Thank you.